So we are having PG clinics as usual, monthly second Thursday. Dr. Siddhartha sir also has joined. Today is Dr. Godhi sir is moderating the thing, today's program, and Dr. Sreevathsa and Dr. M.R.Sreevathsa are the examiners. Two PGs, our chairman already announced. I welcome KSCASI chairman Dr. Rajgopal Shenoy K for today's program. I, on behalf of KSCASI, wish him many happy returns of the day. Happy birthday, sir.
Thank you.
From all of us.
Hi, sir. So we have a birthday boy today in our program. I request him to conduct the program, sir.
Yeah. Thank you. Thank you very much. It's my, proud privilege also to be associated with this today's program, because we have one of the most senior, you can call as our national EC also, former principal, HOD, and my very personal friend and well-wisher, Professor Ashok Godhi, sir. So moderating this session along with the two other eminent very senior people. Dr. Srivatsa, my association again almost dates back to 25 or more than 3 decades. And Dr. M.S.Kotennavar, two are the eminent examiners. And we have the rest of the many in this galaxy here. So welcome has been done to everyone. My request, sincere request is all of you, please mute yourself, except the moderator and two examiners. Two are very interesting cases. One is abdominal mass and another is a thyroid. Both are very important exam cases. And I think any doubts, any things, please put in the chat box. And I take this opportunity to thank each one of you who are here, and also to wishing me birthday. Thank you very much. Sir, without much wasting the time, we'll start the proceedings. Dr. Siddesh, welcome also to this program. Thank you.
Thank you.
Martin, yeah, okay. Please start, first presentation.
Yes.
Yeah, please.
Good evening, everyone. I am Dr. Shivmani, Junior Resident Department of General Surgery, KMC Manipal. My guides are Dr. Rajgopal Shenoy sir and Dr. Sunil Krishna sir. Mrs. Krishnamma, a 61-year-old female hailing from Kundapura, Karnataka, daily wage worker by profession, from a poor socioeconomic strata, was referred to Kasturba Hospital, Manipal from the local hospital after resuscitation with the chief complaints of decreased appetite for last 3 months, vomiting since last 2 weeks, and altered sensorium since last 1 day. Patient was in her usual state of health 3 months ago when her daughter noticed that she has been consuming less food, half a cup of rice as compared to before, when she used to almost eat 1.5 to 2 cups of rice. On inquiring, patient complained of decreased appetite and feeling of fullness after a meal and early satiety. Patient was taken to the local doctor and was given medication for improving appetite. There are no documentations available for it. Since last 2 weeks, patient developed multiple episodes of vomiting, 10 to 15 episodes per day, which was non-bilious, non-projectile, containing undigested and semi-digested food particles, was coffee ground in color, and vomiting usually started after 1.5 to 2 hours after consuming food. Since 1 day, patient developed altered sensorium and was taken to the Taluk hospital, where fluid resuscitation was done. Nasogastric tube and Foley's was secured and referred to Kasturba Hospital, Manipal for further management. She also complains of daughter gives history of easy fatigability and generalized weakness. Weight loss history is there. There's no documentation for the same. There's decreased urine output history for last 2 days. Decreased history of constipation for last 2 days. There's no dyspeptic symptom history, no pain abdomen or rolling sensation in the abdomen. No history of melena or hematemesis. No past history of peptic ulcer disease or corrosive injury. No history of cough, chest pain, hemoptysis, dyspnea, bony back pain, headaches, or seizures. Patient is nil premorbid. There's no past history of surgery. Personal history: patient consumes mixed diet, predominantly vegetarian diet. Appetite is decreased. Sleep is slightly disturbed because of the vomiting. And patient used to pass stools twice a day in the past, but since last few weeks, the daughter tells that the frequency has come down to 1 per day, and since last 2 days, she has not passed stools. Bladder habits are unaltered. There's no history of alcohol or tobacco use. There's no history of cancer or cancer-related deaths in the family. Menstrual and obstetric history. Patient is postmenopausal since 10 years. Para 4, living 4, abortion 0, normal vaginal deliveries. So to summarize, 61-year-old female with complaints of decreased appetite since 3 months with early satiety and feeling of fullness after consuming diet, and history of weight loss and altered sensorium since 1 day associated with constipation and decreased output, came to the hospital, and there's no family history of malignancy or malignancy related deaths. And
in the history,
yes, sir.
You are forgetting to mention vomiting.
So,
in the summary.
Yes, sir. Multiple episodes of vomiting, which were non-bilious and contained undigested and semi-digested food particles, and coffee ground in color also.
I think the diagnosis is easy with the history being given so very well. So any questions on the history? Otherwise, we can go on to the examination.
There is one unusual point in the history, that is the altered sensorium.
Yes, sir.
Which you would like to explain, possible explanation, or you would like to explain it at the end?
Sir, altered sensorium, because multiple episodes of vomiting, almost 10 to 15 episodes per day with not consuming diet. So probably dehydration leading to hypovolemic, severe dehydration with hypovolemic shock kind of features leading to altered sensorium. And on top of that, because of multiple vomiting episodes, there will be dyselectrolemia. Hyponatremia particularly is notorious for causing delirious and altered sensoriums.
Okay.
Dehydration
due to...
Sir, please. Yes, sir, please.
Yep. Carry on.
Dr. Shivmani.
Yes, sir.
Can you highlight about this feeling of fullness after meals? Because patient is in altered sensorium, isn't it?
Yes, sir.
We have to rely on patient's attendance.
Yes, sir.
Okay. Can you elaborate some more? Like what was the feeling of fullness after meals? Was it for solids? Was it for liquids? And you have told decreased appetite is there. I think decreased appetite has to be told as an associated complaint rather than telling as a main complaint, isn't it?
Yes. Oh. Sir, patient daughter gave the
some more. Though we know that patient is not in a state to tell the contribute to the history. Some more elaboration, if you could tell us.
Yes, sir. Patient's daughter gave history that earlier what amount of diet she used to consume, it has significantly gone down despite eating less food compared to before. That is around just half a cup of rice. She's feeling fullness and discomfort in the abdomen, and she's not able to consume more.
Is it associated loss of weight also?
Yes, sir. Which is not documented.
Loss of weight?
Yes, sir. Loss of weight is there, sir. Sir, her weight is around 30 to 35 kgs.
Better if loss of weight is also associated, that can also be told in the history, I feel.
Yes, sir, I have.
Because those 2 points, usually they go in favor of malignancy, isn't it?
Yes, sir. Yes, sir.
This altered sensorium was only 1 day, isn't it?
Yes, sir.
1 day when she went to the hospital.
Yes, sir.
That was when she was taken to the hospital.
Yes, sir.
So 1 episode.
Sir, she developed altered sensorium, and then she was taken to the local Taluk hospital, and there they did the basic resuscitation. And after a day, like early morning hours, she was taken, and in the night hours, she came to us.
Okay, so when she came to you, she was able to give the history?
No, sir.
No. Okay, you said constipation. I mean, what is the definition of constipation here?
Sir, she's not passed stools in last 2 days, so acute onset.
But otherwise, she was passing every day, or at least
Yes, sir.
once. So
Yes.
that's not constipation. What do you how do you explain this symptom?
So probably because whatever she was eating, she was vomiting out. So that is one reason, sir. And because of the it would have been her sensorium would have worsened over
Yeah,
the course of some
correct.
time. It would not have been just 1 day. That is what they are telling. But
Okay. So dehydration and the altered sensorium must have led to her not passing stools for 2 days. Not very important
Shivmani.
anyway.
yes,
Dr.
sir.
Shivmani, better
Yes.
don't say it as constipation, isn't it? You can
Yes,
say
sir.
patient has not passed stools since last 2 days.
Yes,
Because
sir.
as Dr. Srivastsa sir has pointed out, to define constipation, we should know
Yes,
the
sir.
normal bowel frequency, isn't it? What
Yes,
is the
sir.
normal bowel movements frequency?
Sir, it is individualized. Like
No, there is a general this one range for normal human beings.
sir,
Something like two times in a day, two times in a week, isn't it? In
yes,
extremes
three
of that, more than 2 times in a day makes it a diarrhea. Less
diarrhea.
than
Yes,
2 times in a week defines it as
mix. Yes,
constipation, isn't it? So
yes, sir.
definitely it will not be constipation. Say patient has not passed stools since last 2 days, as per her daughters, isn't it?
Yes.
Okay.
What is this coffee ground vomitus? You have to explain the meaning. And at the same time, there should be something else that you should have mentioned as far as the stool was concerned.
Some Malina, they are not
Yeah.
giving history of Malina.
Yeah, did you
I had
mention that?
Yes, sir, I have mentioned in negative history.
Okay, I think I missed it. Okay, all right. So you can go on to examination.
What do you feel looking at this history, Dr. Shivmani? What do you think patient is suffering from probably?
Probably, sir, provisional diagnosis would be gastric outlet obstruction secondary to gastric malignancy, because that explains the vomiting, the poor nutrition, and coffee ground color also because of some sort of bleeding that would have happened because of the gastric malignancy and probably an ulcer.
Right? Because old age patient, isn't it?
Yes, sir.
3 months history of early satiety, fullness after eating after meals, and recent onset of vomiting, isn't it? Is there any possibility of aspiration in this patient?
Yes, sir. She is at high risk of aspiration because one altered sensorium and multiple vomiting episodes also.
There is
So
no
would that
labored
lead
breathing,
towards
isn't it? There is no noisy breathing.
No dyspnea, no stridor history they were giving her. Even on examination, she was fine. But
History-wise, there are no points suggesting aspiration, isn't it?
no.
Even though she gives history of vomiting, there are no features suggestive of aspiration according to your history.
Yes.
So your history findings go more in favor of gastric outlet obstruction, secondary to probably CA stomach.
Yes, gastric malignancy.
Which part of the CA stomach do you feel depending on the history?
So pylorus.
Why not upper end of the stomach or gastroesophageal junction?
Sir, that because if it gastric outlet features to develop, there should be obstruction of the pyloric opening, so that leads to retrograde dilatation and stasis of gastric contents.
Yeah. Though there
In
is
other words,
history
if it
of
is
vomiting of
proximal,
undigested food material, see, GO junction, gastroesophageal junction, carcinoma usually manifest with more of dysphagia, isn't it?
Dysphagia and
Dysphagia
regurgitation.
rather than vomiting. Very good, very good.
Do you
Okay.
straight away exclude duodenal ulcer resulting in duodenal stenosis and gastric outlet obstruction?
So he has told there is no history suggestive of dyspepsia in the past.
Sir, because there is no history that suggests that peptic ulcer disease was there, or she had taken any medication, or she underwent any surgery for the same. It would still consider it, but it would not be the first diagnosis that I would keep in my mind, sir. Cicatrization.
Okay. If there is a
And
bile in the vomitus,
yes, sir.
what do you consider?
Sir,
Suppose in this case,
So that means the level
Every
of
time she vomits bile.
so then level of obstruction would be further ahead of D2.
Yes.
Second part
like,
of duodenum.
Like what?
So not in this age group, but annular pancreas.
Yep. One possibility. Yes.
Uh,
Any other?
Annular pancreas is one, sir.
Any other distal to second part of the duodenum? Any other lesion? Any other lesion? Yes.
Wilkie's syndrome, sir. SMA syndrome.
Okay.
Can
Though
also
they are rare. In this case, possibilities are rare.
Yes.
But just to think about it. Okay.
Yes.
With complaints like this and containing bile, you would be suspecting benign or malignant, even if there is bile beyond the D2. With the complaints that you have mentioned.
No, sir. Malignant obstruction.
Why you can't you have a duodenal carcinoma?
Sir, they are not that common. And
compared to Wilkie syndrome, not common.
And sir, usually they'll have a syndrome like syndromic association with like HNPCs, the duodenal polyp leading to
duodenal carcinomas can also occur without jaundice, right? There's no jaundice. They can produce obstruction. Tubercular strictures can produce obstruction. Keep something which is common than Wilkie syndrome. Okay, fine.
Dr. Shivmani, did you ask any liking of the food by the patient?
Sorry, sir?
Because in this patient, you are suspecting CA stomach, isn't it?
Yes.
I don't think there are predisposing factors are there in this patient. So you have to ask some questions like which type of food she is more likely to eat or more wishing to eat.
Sir,
Hello.
Some people will be happy to
food,
like food, isn't it? Non-vegetarian food like
yes,
smoked
non-vegetarian
fishes, or
smoked
somebody will be
food.
having more this one for pickles, etc.
Yes.
Isn't it? Spicy food.
Preserved
So
food,
that
yes,
also,
sir. Salted
that also
food.
you have to take it in history details.
Yes.
Details of food habits.
Yes.
Okay, especially in personal history.
Yes, I'm predominantly
You
she's
are
vegetarian.
you are ruled out social habits like tobacco, alcohol.
Yes.
But food likings also should be asked, especially in cases like CA stomach. Okay?
Yes. Yes.
Okay, I think we should proceed now.
Yeah.
Yes, sir. Yes, sir.
General physical examination.
Yeah. Go ahead.
General physical examination, sir. Patient was examined in a well-lit room after taking verbal consent from the patient party. Patient was conscious but drowsy. Poorly built and emaciated. She had dry tongue and oral mucosa, sunken eyes and cheeks, skin turgor, skin pinch test more than 2 to 3 seconds, and capillary refill time was also more than 3 seconds. She had severe pallor. There was no icterus, sinuses, clubbing, or pedal edema. There was no palpable workhouse node, Irish node, or final tenderness. Performance status was 3/4. Approximately, patient weighed around 30 to 35 kgs. On further general physical examination, there was Foley's catheter in situ, which had dark straw-colored urine. Nasogastric tube was also in situ, which showed coffee ground-colored non-bilious watery aspirate around 1 liter. 950 to 1 liter was there, sir. On vitals examination, blood pressure was 112/68. Right arm in supine position. Pulse rate was 108. Right radial artery, regular rhythm, low volume pulse, and vessel walls were thickened. Saturation was 95 in room air. Respiratory rate was around 16 to 18 minutes per 16 to 18 per minute, sir. Per abdominal examination, shape and contour of the abdomen.
Any positive findings in the general physical examination, Dr. Shivmani?
Sir, signs of first altered sensorium, poor build, and cachectic appearance. Signs of dehydrations are there, sir. Signs of anemia is there, sir. And
mild, moderate, or severe dehydration?
Sir, severe. She has tachycardia, low BP, and all the
sunken eyeballs you are told. Sunken eyeballs go definitely in favor of severe dehydration. Very good.
Pallor is there, sir. Severe pallor was there.
Instead of telling patient was conscious and drowsy, you can tell in terms of GCS also. Because that is a status of the consciousness level, isn't it?
Yes.
To tell the level of consciousness, you can use GCS scoring.
BMI should have been mentioned here. You have said
Yes. Actually, so we were not able to actually take the weight or the height. We just approximated. She was very lean built and we had no documentation. That's why I didn't mention. It was approximately the 30-35 kg weight.
She was not able to stand up because of drowsiness.
Yes, sir. Sensorium was poor, sir. And the party told that patient party's daughter told that probably based on the history, it looks like they had in the local hospital started her on some sort of supports also before shifting. And after she stabilized, she was shifted.
Go ahead. Go ahead.
All right.
Per abdominal examination, shape and contour of the abdomen was scaphoid. Umbilicus was central and inverted. All corresponding quadrants were moving well with respiration. There was no visible fullness or mass. No visible peristalsis or pulsation was noted. There was no scar or periumbilical nodules. On palpation, superficial palpation, it was non-tender, no local rise of temperature. Soft, no palpable mass. On deep palpation also, there was no palpable mass or organomegaly. Succussion flash was not present. On percussion, the abdomen was resonant all over. There was no shifting dullness. And on auscultation, bowel sound was present and normal, sir. Per rectal examination, no skin tags or fissure, normal tone, but there was blackish colored, sticky, foul-smelling fecal staining of the gloves noted on per rectal examination. There was no palpable deposit in the pouch of Davies. Systemic examination was unremarkable, sir. So in summary, 61-year-old.
Can you go back to inspection, please? The slide on inspection. Shivmani, can
Yes,
you
sir.
put up the slide on inspection?
Yes, sir.
Okay. All right. So you should be able to, say, characterize what peristalsis you're looking for, right? You said no visible peristalsis.
Yes, sir.
You should have been able to put the important word there. Which one?
Visible gastric peristalsis.
Yeah, that should have been better, is it? There's no visible gastric peristalsis. What pulsations are you interested in? I mean, in this patient.
So transmitted because she was very lean and malnourished.
I mean, it doesn't have any bearing here, isn't it? I'm not
Yes.
looking for an aortic aneurysm here.
No, sir.
Yeah. Okay. So it should have been just no visible gastric peristalsis.
Yes, sir.
And I don't think you should put in that pulsation unless there was a mass.
Yes.
Okay. Right. The next slide, please. Put up the next slide. Show us the next slide. Yeah, you say you have mentioned here no organomegaly, no palpable mass or organomegaly. You should be very specific here. No palpable mass, no
Hepatomegaly.
Hepatomegaly. That's what you're looking for, right?
Yes, sir.
The organomegaly is a general word.
Yes.
Looking in specific for a hepatomegaly.
Yes, sir.
Which indicates
metastatic.
A metastatic spread. Yes. Or number one, that is there, and then other masses in the abdomen indicating multiple masses in the abdomen.
Multiple masses in the abdomen.
There could be a mass not specifically related to the stomach, but others.
So pseudomyxoma perit.
Suppose there was a linitis plastica, what would you get? Other places in the abdomen. Peritoneal deposits.
Yes, sir. Pseudomyxoma peritoneum.
No, it's not pseudomyxoma. Peritoneal metastasis.
Yes.
Particularly in a colorectal examination, you would be looking for that, rather than your description. I went through a description, no skin tags, anal tone. When all that is fine for an examination pertaining to an anal disorder or anorectal disease. Here you're specifically looking for deposit in the
Blummer shelf and
Douglas.
Yes.
Okay, so please be very specific when you give such findings.
Yes.
Okay, don't beat around the bush, go directly, bullseye.
Dr. Shivmani, you have told per rectal examination there is evidence of melena, isn't it?
Yes, sir.
Black tarry sticky stool. And then what is the minimum amount of bleeding, upper GI bleeding to produce melena?
Sir, around
Can you tell us what is the minimum amount of upper GI bleed to produce melena?
it's around 500 ml.
500 ml, too much, half liter.
So slow transit time and around 1 liter. I'm not sure, sir, about the quantity amount.
So much. Around 60 to 100 ml. Okay. Minimum 60 to 100 ml bleeding should be there to produce melena. What it signifies? Melena?
Sir, usually it signifies that the bleeding is above the level of ligament of Treats. Sorry, sir?
What it signifies, melena?
That bleeding is above the level of ligament of Treats and
It's upper GI bleeding, isn't it?
yes, sir.
What are the probable causes in this patient?
Sir, in her particular case, we would consider the gastric carcinoma, which has bled because of ulceration, leading to melena, sir.
Yes.
And this explains that coffee ground color also.
Yes. Or second possibility?
Sir, upper GI.
It can be bleeding peptic ulcer, more
Bleeding,
common cause, isn't
yeah,
it? There is possibility. It can be simple bleeding peptic ulcer.
Yes.
Yeah. Okay. Okay.
Go to summary.
Right.
Go to summary. Summary.
61-year-old female with complaints of loss of appetite, early satiety, with weight loss for 3 months, multiple episodes of non-bilious vomiting with undigested food particles for last 2 weeks, presenting with altered sensorium, decreased urine output for 1 day. On examination, she is dehydrated, malnourished, and in hypovolemic shock. Per abdominal examination is unremarkable. On per rectal examination, melena was noted. So impression, the first diagnosis will be gastric outlet obstruction secondary to suspected carcinoma stomach in hypovolemic shock with anemia.
Questions from the examiners?
Yeah, I
What are
think
the
we'll
features
definitely
to tell us
deal
there is
with the
evidence of gastric outlet
diagnosis.
obstruction?
Sir, history-wise, patient is having non-bilious vomiting with undigested and semi-digested food particles following consumption of food. That is one main feature in support of the diagnosis, sir.
You have to tell persistent vomiting. Persistent vomiting for almost
yes.
15 days, isn't it?
Yes, sir.
Not for 1 or 2 days. It is there for almost 15 days.
Yes, sir.
Also, there is history of
Profuse.
bleeding, isn't it?
Yes, sir.
Bleeding because patient has got melena. That may go in favor of CS stomach, or it can be again long-standing peptic ulcer.
Yes, sir.
Which can give rise to gastric outlet obstruction. But taking into account her age, you are telling it as
Malignancy is more likely.
diagnosis of malignancy. Okay.
So
Shivmani?
3 Ps you must
Yes.
have read: profuse, persistent, projectile vomiting as a symptom of gastric outlet obstruction.
Sorry.
Profuse, persistent, projectile vomiting. 3 Ps
Yes.
to remember about the type of vomiting that you get in gastric outlet
Yes.
obstruction.
Okay, Shivmani,
Yes, sir.
are you surprised that there is no visible gastric peristalsis?
No, sir. Because in gastric malignancy, particularly infiltrative type, there may be no visible gastric peristalsis. They may not be grossly distended stomach also. Hence, no succussion splash also.
Why there is no gastric distension in CS stomach as opposed to duodenal ulcer stenosis?
Sir, in benign pathology with duodenal ulcers, it is over the course of a long time. So the stomach distends gradually and becomes very dilated. And in such patients, typical gastric outlet symptoms are usually seen. Whereas in cancer related gastric outlet obstruction, it is very rapid progression. So stomach does not usually distend and does not usually present with typical features of gastric outlet obstruction.
Okay, that's good
See,
answer.
Dr. Shivmani,
Yes.
in this patient has already come to you with in situ nasogastric fluid, isn't it? Hello?
Hello.
Case discussion.
So,
I think somebody has put on unmuted the
It's unmuted.
speaker. So they're talking, overlapping.
Is it okay now? Am I audible?
yes.
Yeah, you are audible.
Shivmani?
Yes, sir.
I have a question.
Yes, sir.
Suppose you find splenomegaly in this case. Can you explain?
Plate etkura.
So lymphoma.
I think somebody is unmuted the speaker. I mean, somebody is speaking, one of the invitees.
I have removed the permissions. I can go ahead.
Okay.
Can you explain a
So
splenomegaly in this case without changing the diagnosis?
So lymphoma can present.
No, without I said without changing your primary diagnosis.
Of gastric cancer.
Yeah. I will make it more simpler. Can you find jaundice in such cases?
So periportal lymph node.
Yes.
If it is involved, it can cause obstructive jaundice. And it can cause extrahepatic portal venous obstruction and splenomegaly.
Splenomegaly, yeah. That's right. Any more questions from the
mass pressing on the portal vein?
Any more questions from the examiners? Otherwise, we can go to management, investigations and management. I think we should proceed to investigations. Management.
Which part of the stomach, Shivmani?
Yes, sir.
Hello?
Yes, sir.
Which part of the stomach undergoes receptive relaxation? Suppose you have a duodenal obstruction, benign nature. There is a receptive relaxation
So
to accommodate.
So this when the food goes to the stomach, there's receptive relaxation, particularly of the antrum, because that is where the churning action happens against the closed pylorus.
It's upper end of the stomach, which can relax and become huge, which is the fundus.
So corpus and fundus usually distance grossly when
they undergo relaxation to accommodate more food. So you have a benign obstruction, they dilate first.
Sorry, sir?
When you have a benign obstruction to the pyloric area,
yes, sir,
this part of the stomach distends first because they have the capacity to accommodate and relax compared to the distal part of the stomach. Okay, you go on to
management. Go ahead with management.
Yes, sir. In this particular
case, did he answer that, Dr. Shreyas? Did he answer that question?
Yeah, no, I had to give the answer.
Please, because we have 10 more minutes.
Yeah, we have given him the answer saying that receptive relaxation is by the fundus of the stomach, proximal part of the body, than the intrum.
Okay. Go ahead, Shivmani. Management.
Sir, in this particular case, the first thing would be resuscitation and decompression, sir, when the patient comes to casualty in this particular case, and stabilization of the hemodynamic status.
Don't say decompression. Decompression of what? You should
be specific
again. Yeah, decompression of the stomach.
What
is the resuscitation that you're talking about? Can you just summarize the resuscitation, which is very important here?
Sir, first thing would be to give a bolus of Ringer's lactate or normal saline 0.9% and see for the response, sir.
Which do you want to use, Ringer's lactate, normal saline?
Sorry, sir?
Which one you want to use, Ringer's lactate or normal saline?
So Ringer's lactate is the more physiological of the solution. So
Without knowing urea
renal,
creatinine, you want
yes,
to give Ringer's
no,
without
sir.
knowing
Renal
urea
status,
creatinine.
yes, sir. Because in this particular case, urine output was low. So we would like to give saline first, because Ringer's lactate is potassium rich. If patient has a acute kidney injury, then hyperkalemia can be worsened because of Ringer's lactate itself. So
Could the
normal
patient
saline.
have alkalosis also?
Sir,
Patient be having alkalosis because
yes,
of
sir. It will
resistance.
be expected in such cases, sir, because they'll have, because of profuse vomiting, they'll be having hyponatremia, hypochloremia, hypokalemia, and
So
metabolic
hence
alkalosis.
your Ringer's lactate will add a little alkali also, if given
Yes.
parenterally. Initial stages there is alkalinization. Yes.
Proceed.
So yeah, you will resuscitate with crystalloids.
Yes.
Yes, go on. How will you monitor your resuscitation with crystalloids?
Sir, after giving the bolus, we would like to see if the patient has responded, if blood pressure has picked up, tachycardia is settling, and urine output is picking up or not. Clinically, these things can be used, and betterment of sensorium also is one of the parameters that we can use, sir. And based on particularly blood pressure, we can classify them as transient responder, non-responders, or responders. Transient and responders usually will fare well with continued fluid resuscitation. Non-responders may require inotropic support for stabilization, sir.
Okay, basically urine output, sensorium, and also venous pressure monitoring.
Yes, sir.
Okay.
Okay, first is
Resuscitation done.
resuscitation fluid, then
Sorry, sir.
Next.
resuscitation. Next,
Sir, after that, we would like to, while resuscitation is happening, we would like to send a certain blood test, complete blood picture, renal function test, serum electrolytes, ideally an ABG also, and liver function test with albumin.
You would like to add packed cells if our hemoglobin is 6 grams? Packed cells volume? Packed
there's
cells.
already severe
Sir,
failure.
yes, a complete blood picture with hematocrit.
No. In the treatment, that is investigation. In the treatment, would you like to add packed cells transfusion? Packed cell
Sir,
transfusion.
Yes, sir. This patient, because she is anemic, and once we confirm that with the complete blood picture, she would require optimization, which would require PRBC, packed red blood cells transfusion.
Okay, complete hematological, biochemical investigations are done. Okay, and electrolyte imbalances are corrected. Hydration is improved. Next.
Sir, ultrasound of the abdomen and pelvis would be as an extension to the clinical examination to rule out any ascites and liver deposits particularly. And once those two are ruled out, we can, and once patient is stabilized, we can further go ahead with upper GI endoscopy or OGD to characterize the lesion.
Before upper GI endoscopy, would you like to take a chest X-ray?
Yeah, chest X, sorry.
Chest X-ray, yes. Then upper GI endoscopy.
Upper GI endoscopy, yes.
Chest X-ray is normal. Sonography, no liver mets, no ascites. Assume, proceed.
Sir, in upper GI endoscopy, we would like to take the biopsy from the lesion, if identified, and characterization of the lesion also and that biopsy, once biopsy results are out, we can plan for further management. But in this particular case, she would require operative intervention to relieve gastric outlet. But before that, once stabilized, we have to get a CECT abdomen and pelvis and thorax. Abdomen and pelvis.
Wait. Endoscopy, there is no ulcer. And there is no ulcer in the stomach. So would you like to refine your diagnosis? There is no ulcer. It is smooth mucosa.
Sir, there may not be any ulcer if it's a linitis plastica in lymphoma, and in GIST also, because they are of submucosal in origin. may have small ulceration in later stage, but usually they are extrophytic. So they may not grow into lumen initially, sir.
How
So
would
in
you
this
take a
case,
biopsy if it is
what
a
would you suspect? If the
linitis?
mucosa looks thick.
Sir, if it is linitis plastica, we take bite or a well biopsy. From the biopsy point, we take one more deeper biopsy so that we get putative site proper biopsy, which can give definitive diagnosis. Because superficial biopsy may not be conclusive.
Okay.
One important thing in the investigation that you forgot before you went on to, planning the surgery. What was that?
Chest X-ray done, sonography done, CT done, but one more investigation is required, where you can image the surrounding structures more
EUS,
closely.
Endoscopic ultrasound.
Endoscopic ultrasound. Yeah.
For T stage, particularly to differentiate T and T1 and T2 and T3 and T4 also, it can differentiate well. And for perigastric lymph nodes and nearby lymph nodes in periportal region also, it can detect, and behind stomach also particularly.
Yeah.
So what is your next course of action? Let's say it is a locally infiltrative antral type of carcinoma, confined to the antrum, locally infiltrative, and the peritoneum
no lymph
liver
nodes.
is normal.
No lymph nodes.
Sir, if patient is fit to receive.
Not if. This is a patient. You have got a patient in front of you.
So this particular case, we have to go for surgery because perioperative chemo is not a possibility in her case because she is in gastric outlet obstruction.
Do you think patient is fit for surgery? Fit to undergo surgery? What type of surgery are you planning? Resection or palliation?
So in her particular case, we would think about palliation for relieving the gastric outlet obstruction first.
No. Understand the question.
Resectable tumor, you're going to palliate.
She is fit for surgery. She has been made fit for surgery. Her hemoglobin has improved, hydration has improved, and she is fit.
Sir, then distal gastrectomy, distal radical gastrectomy with D2 lymphadenectomy would be the surgery of choice.
Will she survive this? One important factor again, you forgot: electrolytes, fluids,
nutrition.
Fine, nutrition. How are you going to improve that? That's a very, very important prerequisite here before you can do an ablative surgery, a resectional surgery. When anastomosis will simply break down.
Yes, sir. Nutritional status has to be taken care of. That is
so what are you going to do about it? So you see, an LFT should have spoken about albumin, pre-albumin status.
So albumin and pre-albumin are two tests that can be done biochemically, which will tell about the nutrition status. Albumin can be deranged sometimes if patient has infection or inflammation. So pre-albumin is superior to albumin in that regard. Values are not. It's not a acute phase.
So let's cut it short and say, how are you going to improve the nutrition?
Sir, for this parenteral nutrition is one option for her for improving nutritional status. Other option can be. Sorry, sir.
What else? Yeah, option. You're talking about options, right? One is parenteral nutrition. Yes, correct. Then
other option can be, sir, feeding jejunostomy can be done for her, and after 4 to 6 weeks, once the nutrition improves, we can reassess and replan for definitive surgery.
Okay.
Is it? Would you like to try?
By
yeah, go ahead, sir. Go ahead.
Relieve the obstruction temporarily by some means, some methodology that you can.
Lumen opposing metallic strengths are available now, which can be put, and endoscopically gastrojejunostomy can be done to relieve gastric outlet obstructions.
It's not anastomosis. You're not talking about anastomosis here. Okay, you have to either balloon dilate or a stent.
Yes.
Dr. Shivmani, can you tell us the signs of inoperability in a case of CA stomach?
Sir, ascites with cytology positive, peritoneal deposits, periaortic lymph nodes, if they are positive, and then if celiac plexus involvement is there, gastric bed involvement, pancreatic infiltration is there, or distant metastasis is there, or proximal hepatic artery involvement and proximal splenic artery involvements are also considered criteria for inoperable.
Is it same as undissectable tumor? Inoperable tumor, is it same as undissectable tumor? Or they are the different entities? Sometimes a tumor, though it is operable, it can be undissectable.
So
Isn't
because,
it?
yes,
Are they same or different entities?
no, sir, unresectable tumor because of involvement of certain structures like hepatic artery makes it unresectable, even though the tumor stage may not stop or like makes it operable. But features like distant metastasis and ascites with cytology positive and peritoneal deposits make it inoperable.
Yeah. It's mainly depending on the local spread, isn't it? Mainly the local spread of the tumor. Very good.
Okay,
So in
we
this
have
case, what you are saying?
we have just 2 minutes. Can you mention some palliative surgical procedures in this case? Palliative.
Which is the best mode of palliation,
Which is the
Shivmani?
best
Best mode of
palliative
palliation.
surgical procedure?
Sir, anterior gastrojejunostomy, anticolic anterior gastrojejunostomy can be done for relieving gastric outlet obstruction as a mode of palliation.
Have you heard of any exclusion operation? Any exclusion operation?
So pyloric exclusion, but that is,
What is it called as? What is the name?
I'm not sure.
Yeah, how is it?
The best way of palliation is palliative resection. That's the best way of palliation. But again, you have to improve the nutrition before you can attempt this type of palliation also. You have to improve the nutrition and then only go for palliation.
Yes.
Even now, even for palliation, you have to improve.
Yes.
Yeah, your answer should be, if patient is operable, the best mode of palliation is again palliative resection rather than anti-rage GJ, isn't it?
Not
Yes, that
should be
operable
the
for
answer.
cure. Patient not operable for cure. Your patient best palliation is resection, palliative resection.
Yes.
Why not posterior GJ,
I
Shivmani?
mean, my point here is in this patient, in this condition, poor nutrition,
In this condition, you
and
can't.
I think quick palliation should be GJ, because resection is going to take time, and she may not survive the resection. I think the quick palliation can be obtained by GJ. I think.
Yes, yes.
In this patient,
The
in this
best
patient,
thing
in this
would be an
condition.
endoscopic stent, sir. Self-expandable metallic stent
Huh.
would be the least invasive method.
Okay.
Sir,
Agreed.
anterior GJ because tumor usually grows posteriorly, and if you were to do a posterior gastrojejunostomy, that may get
No,
occluded
we
again.
are not asking you that question.
No, sir
No,
asked.
no.
Yeah, I was asking, sir. I was asking, why not posterior GJ?
You asked that question. Okay.
Yeah.
Okay. I think you forgot about the nutrition support. That's a very important point Dr. Srivathsa brought about. I think you forgot about nutrition support in such patients. Only electrolyte imbalance correction, dehydration is not going to improve the condition of the patient. But nutrition is extremely important in this condition, in such patients.
Yes, sir.
I think we should wind up this case because we have any
Next
comments
case.
by the examiners about his performance. I think he did well.
Okay, sir. Dr. Shivmani
He
has
did
done
well. He did well.
wonderful
He has done
presentation.
well.
Any comments by Dr.
I would say he has
Kotennavar?
done very well.
So he has presented well, sir. Almost many of the points he has told voluntarily.
Yeah.
He could able to answer the questions also.
Huh.
I think it was a fair presentation, sir.
Yeah. Look at the guide. His guide.
Yes, the Dr. Rajgopal.
Credit goes to the guide.
No, sir. No,
Yes.
sir. No.
Also goes to the guide.
No, sir.
Definitely.
So,
Okay. Shall we go to the next case?
Yes, sir.
yes, sir.
Thank you, Shivmani. Thank you.
Thank you, sir. Thanks a lot.
Thank you,
Thank
Shiv.
you.
Well done,
Thank
Dr.
you.
Shivmani. Well done.
Well done. Well done.
Thank you, sir.
We invite the next presenter.
Dr. Shreyas, can
Shreyas,
you
what's
make it
happening?
slideshow?
So, can you hear me, sir?
Yeah,
Yes,
but
yes.
Yes,
Yeah.
your
Yes,
the
Doctor.
slides are
Yeah,
not there.
yeah. 1 second, sir. Yeah. Okay. Good evening, respected teachers and my dear colleagues. My name is Shreyas Ranganath. I'm from M.S.Kotennavar Medical College, junior resident, and my guide for today is Dr. Shrikar sir. So this is a 33-year-old female hailing from Midnapur, West Bengal, who has studied till 10th standard as homemaker by occupation.
Homemaker is
came
not
with-
an occupation. Just a homemaker.
Yes,
Huh?
homemaker. Yes. She came with chief complaints of swelling in front of the neck since 6 months, complaints of difficulty in breathing since 3 months, and complaint of difficulty in swallowing since 2 months. History of presenting illness. Patient was apparently well 6 months ago, following which she noticed a swelling in front of the neck, which was insidious in onset, progressive from an initial size of 2 into 1 centimeter to a current size of around 5 times the initial size in 3 months. Swelling associated with pain since 3 months, which was dull aching type, which aggravated on eating and relieved on rest. Patient also gives history of difficulty in breathing on lying down since 3 months, for which she turns towards the side to sleep, and difficulty in swallowing since 2 months, more for solids than liquids. History of rapid increase in size is present. No history of hoarseness of voice. No features of hypo or hyperthyroidism. No complaints of other swellings in the neck. No complaints of bony swellings. No complaint of cough with hemoptysis. No history of similar complaints in the neighborhood. Past history, there is no history of radiation exposure to the neck. There's no history of taking goitrogenic drugs. Patient has no comorbidities. Menstrual history, the patient attained menarche at the age of 13 and she is having regular cycles 4 to 5 days for every 28 days. Personal history, diet is mixed, appetite is normal, bowel and bladder is regular, sleep is disturbed. There is no history of consuming alcohol or smoking. There is a family history, there is nothing significant. Summary, a 33-year-old female who came with complaint of swelling in front of the neck since 6 months, associated with pain, difficulty in breathing and swallowing with compressive features, and no features of hypo or hyperthyroidism.
I think if
In
you
the
add
summary, something is
just
missing.
go back. Go back to
Something is missing in the
summary.
Yes, sir. Yes, sir.
In the first line, you should add complaints of rapidly increasing swelling.
Yeah.
Okay, sir.
In 3 months.
Okay, in 3
Yes,
In
sir.
3 months, it has increased rapidly.
Okay, sir. Yes.
But then in the family history, you did not mention anything about how many children she has delivered, what is the gravida, what is the para. She's
Okay, sir.
married. She's married homemaker. She's married.
She's married homemaker, sir. She has one child. She conceived that, like, she had that child when she was around 25 years of age. Yes.
Okay.
Yes.
Any more questions from the examiners about the history?
You're asking family history, nothing significant. What is the meaning of that? What were you trying to imply?
Sir, if there is any history of any thyroid malignancy, or if there is any history of, for example, multinodular Goitre in the family, because all of them are from the same region and they could be having the same complaints too. So I'm trying to try to diagnose with the help of these things. What could the possible cause be?
What percentage of malignant goiters are familial? Less than 10%.
5%, sir. 5 to 10%,
exactly. So it's not important. Okay.
Yes,
The
sir.
other reason for asking family history is what type of deficiency can give rise to goiter in the family? What methodology can give rise to goiter?
If they are consuming any goitrogenic food, which will
in the
cause
family,
um,
enzyme
yes, sir,
deficiencies,
enzyme deficiencies. Thyroid peroxidase enzyme
genetically
deficiencies.
inherited. What do you group them under?
Disharmonogenesis.
Disharmonogenesis. Okay.
Yes.
Okay.
Yes.
So in the summary, what do you suspect? You have a patient who is adult,
Swelling in the front of neck.
Yes,
who
sir.
has got a rapidly increasing size of the swelling or goiter with all compressive symptoms and pain.
Yes, sir.
What would you keep in mind?
So I'll be suspecting it is a thyroid malignancy, sir, because of its rapid growth and the swelling moving with degradation, all tending towards thyroid. The thyroid being the main organ which is affected over here. So yeah, so thyroid cancer would be my first diagnosis going with the above history.
Which
sir.
type of malignancy? I mean, you should not say thyroid malignancy, probably this type of malignancy.
Yeah, thyroid malignancy, probably it could be a papillary carcinoma, which is rapidly growing because of the age. Yes, sir. I would tend towards this.
Papillary carcinoma doesn't grow rapidly. No.
Okay, sir.
Which carcinoma grows
Anaplastic
rapidly?
anaplastic carcinoma.
Anaplastic.
Yes, sir.
Follicular.
Also, you should mention, Dr. Shreyas, whether the patient was apparently all right 6 months back.
So 6 months back, she was completely fine, sir.
Because many times what happens, there will be some small size swelling, which was usually
Yes.
which get ignored by the patient. By the time they develop associated complaints in the form of pain or compressive symptoms, then only they give importance. They will tell the history, isn't it?
Okay.
In this
Yes,
case,
sir,
it is possible that patient may be having swelling before 6 months also. That is possible.
Yes, sir.
Isn't it? Pre-existing
Yes,
goiter, later on turning into malignancy. If this is the
Yes,
case,
sir.
which malignancy do you expect? Pre-existing goiter with rapid increase
Yes.
in the size of the swelling, which malignancy
Yes,
do you
sir.
expect?
Follicular carcinoma, usually, if there is a previous history of
If
goiter.
this is the history, you can tell possibility of follicular carcinoma.
Yes.
So you have to spend
In
much
other
time
words,
with
is
the
she from an
patient.
endemic area? Is she from an
Yes, sir.
endemic area?
Midnapur is an endemic area because it comes along the Himalaya region belt. So,
Okay, so
yes, sir.
endemic area, the patient might have had a swelling which was not noticed, and it can turn into whatever you said just now, follicular variety.
Yes, sir. Yes, sir.
Okay.
Go ahead. Go ahead.
What are the pressure symptoms you expect, Dr. Shreyas?
So I didn't understand, sir.
What other pressure symptoms do you expect in such cases?
So dysphagia, dyspnea, they could be even, since it's rapidly growing, it can be even be compressing the esophagus, and it could other things we could expect it involving the recurrent laryngeal nerve since it's growing fast. Yes, sir.
Because by the time a goiter produces compression on the esophagus in the form of dysphagia, you would get the hoarseness of voice, you would get some reduced tone of the voice because compression of the external laryngeal nerve, isn't it?
Yes, sir.
It is last. I think esophagus should be the last to get compressed.
Yes. Yes, sir.
Isn't it?
Yes, sir.
Since it is a muscular organ.
Yes, sir.
Shall we go ahead?
Yeah.
Yes, sir. Please proceed.
Yeah. General
Proceed,
physical
proceed.
examination. After obtaining consent in presence of a female attender, patient examined under adequate lighting. Patient is moderately built and nourished, conscious, cooperative, and well-oriented time, place, and person. Patient is calm and composed with no excessive sweating. With a BMI of 24.3 kg per meter square, there is no pallor, icterus, cyanosis, clubbing, generalized lymphadenopathy, or pedal edema. Vitals: pulse 86 beats per minute, normal in rate, rhythm, volume, character, no radial or radiofemoral delay. Blood pressure of 120 by 70 mmHg and respiratory rate of 18 cycles per minute. This is the picture of the thyroid swelling. I marked it over here so it's easy.
एक और बार रुको.
So, examination of the neck on inspection. A solitary swelling of size 5 into 4 centimeters vertically avoid noted in front of the neck towards the right side, extending superiorly up to the thyroid cartilage, inferiorly 1 centimeters below the sternal, above the sternal notch, laterally just short of anterior border of sternocleidomastoid. Swelling moves with deglutination. Lower border of swelling visible. No dilated veins. No other visible swellings. Plane of the swelling is deep to deep cervical fascia. On palpation, patient examined from front and back. There is no local rise of temperature. It's non-tender. Inspectory findings are confirmed. A solitary swelling vertically overt of size 5 to 4 centimeters noted in front of the neck, more towards right side, extending superior up to the thyroid cartilage, inferiorly 1 centimeter above the sternal notch, laterally just short of anterior border of sternocleidomastoid. Nodular surface with well-defined margins and firm in consistency. Mobile in horizontal direction, deep to deep cervical fascia. Left lobe of thyroid not palpable with Leahy's method also. No other swellings palpable in the neck. Bilateral carotid artery palpable in the normal position. Trail cile negative. Cocker's test negative. Auscultation, no bruit heard over the superior pole of thyroid. Systemic examination, CNS, no focal neurological deficits. CVS, S1, S2 heard, no murmurs. RS, bilateral air entry present. Normal vesicular breath sounds heard. Per abdomen, no distension, soft, non-tender. Provisional diagnosis of multinodular goiter.
Go back to slide on inspection, please. Go back to the slide on inspection.
Yes.
Okay. Yeah.
Yes.
Is there no mention here about the surface of the swelling on inspection?
Surface
what
on
is
inspection
the nature
appears...
of the surface? No. We are talking about the swelling on the anterior aspect of the neck. First thing, people want you to say anterior aspect rather than front of the neck. Okay, that's first correction. Okay. Second thing is your shape, size, extent is mentioned, but not the medial extent. You have not told us about the medial extent of the swelling.
Yes, sir.
And thirdly, the surface and borders here.
Okay, sir.
Are you able to make out what is the nature of the surface inspection and the borders on inspection?
Sir, on inspection, the surface appears smooth and the borders are well appreciated, sir.
Yeah, in inspection you are told smooth surface.
Why do you mention the...
Yes, sir.
Yes.
So your plane of the swelling should not come here.
Okay,
on
sir.
inspection, you are not supposed to tell us the plane of the swelling.
Okay, sir.
I'm seeing it for the first time, so I'm a little surprised.
Okay, sir.
What do you say, Dr. Godhi?
Yes, plane of the swelling is a palpation finding. Agreed.
Yeah. Okay.
And he has missed. He has missed medial border. He has missed. He has missed surface. Yeah. Yes. Go to the palpation. Yeah. Next slide.
Palpation. Next. First thing I want to point out is that trial sign is on inspection.
Okay, sir.
Trial sign should come on inspection. What is trial sign?
Trail sign basically, sir, whenever there's tracheal deviation, the clavicular head of the sternum muscle becomes more prominent because the pretracheal fascia encloses both of them.
Okay. So here, yes, sir.
My question is about mobile in the horizontal direction, deep to deep cervical fascia. Yes, how do you explain this? And is it the correct way to put it? Thyroid is mobile in the horizontal direction. If you say you are saying that it is independently moving apart from the other structures in relation to thyroid. Do you mean it independently moves horizontally apart from the other structures which are deep related to the swelling?
No, sir. It has
you
to
understood
move with them,
my
so
question?
Understood, sir. Understood, sir. It has to move with the structures.
Yes.
What
Which
structure?
structure? Which structure?
With the trachea, cricoid,
Trachea.
cartilage,
It moves with
everything
the
like
trachea. You
moves.
cannot move.
Trachea.
You cannot move it on the trachea. It moves with the trachea.
Yes, sir. With the trachea. Yes, sir. It moves with the trachea.
When it loses mobility, totally it loses mobility. When does it lose mobility, horizontal mobility?
So when there is extratheral extension, it loses its complete mobility, sir.
Mobility, right.
Which
In
type
Palpatine, you
of
have mentioned
malignancy
solitary
would
swelling.
that be? Which type of malignancy would that be?
So anaplastic
Where you
carcinoma.
are, yeah?
In anaplastic carcinoma, sir, it has.
Anaplastic carcinoma.
Yes, sir.
See, anaplastic carcinoma extending into a particular structure makes it immobile. Which structure does it infiltrate into to make it immobile?
It can go
It
to
loses
the.
both movement with gluteus also.
Sir, if
What
there
is
is.
what is the fascia deeper to the thyroid? Deeper.
Sir, prevertebral fascia.
Prevertebral fascia.
Yes.
Vertebral fascia. Yes. Prevertebral fascia and the trachea is up. Everything
Yes.
gets infiltrated. Soft tissues. See, in a well-differentiated carcinoma, you would expect anterior infiltration first. That is the pretracheal muscles, and then the surrounding structures. And it infiltrates everywhere.
Okay, sir.
So here you said it is deep to deep fascia. Why are you saying deep to deep fascia? What made you think it is deep to deep fascia?
So I did the test where you contract, you give resistance when the patient is trying to flex his chin, sir. At that point of time,
Flex his neck. Flex his neck.
Yes, sir. Flex his neck. Yes, sir. Flex his neck, where we can try to observe we can try to get the plane of the swelling, which is deep cervical fascia in this case.
See, the fact that it moves with deglutition, indicates that it is deep to deep fascia. Right?
Yes, sir.
First of
Yes,
all.
sir.
Second thing is in unilateral swellings, that means one lobe, unilobar swelling,
yes, sir.
You can put one sternomastoid, that is ipsilateral sternomastoid, into contraction.
Yes, sir.
So how will you put the right sternomastoid into contraction?
So we
just
tell the patient.
Ask you. It is not necessary once it moves to deglutition. Okay.
So we
how will you put right
tell the patient.
You are right. It says please.
So we hold the left side of the jaw and we tell the patient to turn towards laterally against the resistance. So at that point of time, the sternomastoid on the side it contracts, so we can see at that point of time.
Which side? Say right sternomastoid. Which side are you pushing the chin again as resistance, not the jaw? Chin again as resistance.
Yes, sir.
Chin again as resistance towards. When the patient is moving the chin towards, right or left?
So left side, sir, for this.
Left. Okay.
Yes. Okay.
All right. And then you have said here you put trial sign negative. It should not come here.
Inspectory finding, yes, sir.
Okay. What is Leahy's method of examination?
So Leahy's method of examination is used to palpate the lateral margin of the swelling, sir. Where, for example, if this is a right-sided swelling, we use our left hand to push the swelling laterally towards the right side and try to palpate the margins of the swelling.
Okay, so you're sure that the right lobe has got multiple nodules?
Yes, sir.
Because on inspection it did not appear so.
Yes, sir.
So which method of examination would be useful to make sure that, confirm that there are nodules?
Kreil's method.
Kreil's method. So have you mentioned that? You're not?
I've not mentioned it, sir.
Okay. All right. And where will you palpate the common carotid artery? Will you palpate external carotid or common carotid?
Well, palpate common carotid, sir. We palpate at the level of C6, which is the level of thyroid cartilage, against the C6 transverse process, sir.
So why does the common carotid bifurcate?
So common carotid bifurcates at the level of C4.
No C4 here. I can't see the
Thyroid.
C4. At the level of? I'm not able to hear you. Shreyas,
Yes, sir.
at what level does the common carotid bifurcate?
Sir, at just above the thyroid cartilage, sir, which corresponds to C4 level, sir.
At the superior border or the hyoid bone?
Yes, sir.
Okay. So if you are not able to feel the common carotid on the ipsilateral side, you would call it as?
Sir, it could be encased by a tumor. At that point of time, we won't be able to palpate the common carotid, sir. And
But that's
that is
sign
very,
for, right?
So
very,
what
very,
sign would you
very
call that
sign,
as?
very sign,
Very
very.
sign.
Yes.
Very sign. So how will you palpate here? You have to palpate the trachea next. How will you palpate? Did you palpate the trachea to see whether it's in the midline or deviated?
Yes, sir. I did it. So we
Because
use
we
the,
are not looking at trial sign here.
yes, sir. So we use our
You have not mentioned whether the trachea is central or not.
yes, sir. So we use our index finger to keep on the medial end of the clavicle and our ring finger on the left side of the medial end of the clavicle, and we use a middle finger to trace the trachea out and to see if there is any deviation, sir.
Okay. So was there any deviation? Because you are not mentioned that.
There is no deviation, sir. I'm sorry I didn't mention there is no deviation, sir.
Would you expect a deviation in this patient?
In this case, it's not there, sir. But if it's large enough, since it's only
Look at the
single-sided,
history.
since it's single-sided,
the
yeah, we can
history.
expect it.
There is no if. This is the patient.
Yes.
You have to say. There is no if. There is no if here, isn't it?
Yes, sir.
You're seeing a patient.
Yes, sir. Since it's only on one side, the swelling is only on one side, we can expect tracheal deviation to the other side, sir.
Yep. Yeah, particularly when there is history of difficulty in breathing, particularly on lying down, right?
Yes, sir.
So maybe, I'm not saying sure, maybe you're not examined the trachea properly. What else have you missed in this palpation? What else? A third structure adjacent in the vicinity of the thyroid. One is trachea, second is carotid.
Lymph nodes.
Lymph nodes, sir. Yes, sir.
Lymph nodes.
Yes, sir.
Tell now at least.
You said
tell now.
Lymph nodes are not palpable, sir.
Mention that.
Yes.
Which lymph nodes are you looking for? Which lymph nodes?
So we are looking for level 6 lymph nodes mainly, or level.
No levels here. Please mention the names.
The pretracheal pleryngeal lymph nodes, or upper jugular, middle jugular, lower jugular lymph nodes.
All three. Upper jugular.
So mainly lower, like middle and lower jugular, like 4 and 5.
So you tell us the levels now of the jugular.
Sir, corresponding level of hyoid bone above that is level 2. Below, between hyoid bone and cricket cartilage is level 3, and below cricket cartilage is level 4, which is anterior to the sternocleidomastoid, sir.
What's level 5?
Level 5 is posterior to the sternocleidomastoid, sir.
Which group is that?
That is posterior triangle group of lymph nodes, sir.
Supraclavicular, right?
Yes, sir.
5B
yes,
is what you're looking for, not 5A.
Okay, sir.
So 2, 3, 4 can get involved, but most commonly
3 and 4.
Yes. Then it goes to 2 and 5 later.
Yes, sir.
What is okay? Then your next slide, please. After this, systemic examination.
System, yes, sir.
Why did you auscultate at the superior pole of the thyroid?
So superior pole, I auscultated because the superior thyroid artery is more superficial, and it directly corresponds to external carotid artery. So
Directly
corresponds to external carotid artery, sir.
Corresponds mean, I mean, you're not putting it properly.
Arising,
That
arising.
word.
It arises from the external
direct branch.
direct branch of external.
Unlike inferior thyroid. What is peculiar to inferior thyroid?
Sir, inferior thyroid is a branch of thyrocervical trunk, which is again arising from the subclavian artery, sir.
Okay.
Yes.
So how does it traverse to reach the thyroid? You're saying it is deep. How deep is it? To what structure is it deep?
So
it runs up and then goes behind what structure to reach a thyroid?
Runs up. Sir, a recurrent laryngeal nerve?
Yeah, it crosses it. Of course, crosses. It crosses.
Yes,
it crosses the.
Yes.
It goes behind, courses behind common carotid.
Common carotid. Okay, sir.
So it's deep.
Deep. Yes, sir.
Yeah. So go to your systemic examination, please.
Yes.
No,
what exactly were you trying to look for?
Sir, I'm trying to look at any, for example.
I see per abdomen.
Yes.
Per abdomen, if you suspect any thyroid, even if it is a multinodular goiter,
yes, sir.
There is no, business of examining abdomen. I mean, to mention, you would do, but it's of no consequence.
Yes, sir.
If it is malignant, will you expect hepatomegaly?
Yes, sir. There could be metastasis to the liver.
The only carcinoma, only malignant thyroid which might go to liver is
anaplastic carcinoma.
Medullary
carcinoma.
Well differentiated carcinomas don't spread, so you don't have to mention hepatomegaly. But you missed something here, which is important. Breast bronchogenic prostate.
Yes, sir. From those they can be secondaries to the thyroid gland, sir, from breast. Yes, sir.
I gave you a hint, which is missing here.
Sir, I didn't get you, sir.
No, what metastasis do you expect? Common site of metastasis, apart from lymph nodes.
Common.
When I mentioned bronchogenic, kidney, breast, I gave you a hint.
Mediastinal lymph nodes.
Bone.
Yes, sir.
Skeletal metastasis.
It can, skeletal metastasis.
Which is important.
Yes, sir.
Never ever forget.
Yes, sir.
When you go to systemic examination, bony metastasis.
Yes, sir.
Yeah, it's not good to forget bony metastasis.
Yes.
And then the lungs. And then okay, lymph nodes, bone, lungs.
Yes.
Shall we proceed?
Next slide.
Shall we proceed?
Yes,
Shall we
sir.
proceed?
Yes, sir. Yes, sir.
Yeah. Proceed.
Please, sir.
So provisional diagnosis of multinodular goiter of right lobe of thyroid in euthyroid state with compressive symptoms, sir, is my provisional diagnosis.
Now see, multinodular goiter, how frequently it causes hoarseness of voice, and the size that you have shown in the picture is not big enough to cause compressive symptoms.
Yes, sir.
On the esophagus.
Isn't it?
Yes, sir.
Suppose we give you a finding that the surface is irregular. Instead of saying nodular, you say surface is irregular.
Yes, sir.
What would be your diagnosis?
So it would be a papillary carcinoma of thyroid in this case.
So one more component is missing in your provisional diagnosis, Dr. Shreyas.
Yes, sir.
Dr. Shreyas.
Yes, sir.
At the end, you have to tell probable pathological diagnosis also, isn't it?
Sir. Yes, sir.
Probably because of the compressive symptom, it could be malignant, sir. Which malignancy again?
Over here, multinodular goiter, usually follicular carcinoma will come.
Maybe whatever it is, you have to add that at the end.
Yes, sir.
Pathological diagnosis, probable pathological diagnosis.
Yes.
Now see, for multinodular, multinodular goiter, generally history is a long-standing thyroid swelling,
Long-standing.
Yes.
and then it develops malignancy,
Yes.
and then it starts rapidly growing.
Yes, sir.
Yeah.
And that sort of history is missing here, isn't it?
Yes, sir. It is.
The entire history is a short history.
Yes, sir.
So why do you think of multinodular goiter? Generally, multinodular goiter history is long.
Oh, yes, sir.
Many years, sometimes many years.
Um,
So why don't you think of straight away malignancy? Straight away malignancy, papillary carcinoma thyroid or
Yes, sir.
follicular carcinoma thyroid.
Yes, sir.
De novo.
Yes, sir.
Why don't you think of that diagnosis as a first possibility?
Yes, sir.
No,
So,
you are saying yes, sir. You
yes,
should just
yes.
justify. Justify.
sir, in this case, yeah, we can consider those also because of the compressive symptoms, what it's causing, and of the the short duration of the growth. So we can consider papillary or follicular carcinoma of thyroid in this case.
Okay.
Yes.
Suppose the surface is smooth, what would be your diagnosis? Suppose, let's say this is a smooth surfaced swelling and the margins are round and well defined.
So
What would be a
adenoma, sir?
clinical diagnosis?
And
Clinical
adenoma?
diagnosis.
Adenoma?
Clinically, the adenoma and all that comes pathologically.
Okay, sir.
That's pathological.
Solitary nodular goiter, sir?
No,
solitary
Shreyas,
nodular thyroid.
Yes, sir.
Shreyas, you can't ignore hoarseness here. Adenoma will not cause hoarseness.
Sir, in this case, there is no hoarseness, sir.
No, in history is there no hoarseness of voice?
There is no hoarseness of voice.
No, sir, there is not one.
No hoarseness of voice.
No
Okay.
hoarseness. The
Okay,
compressive symptoms, significant compressive symptoms.
Okay, no hoarseness.
Even for solids.
Yes, sir. She's
So
having.
you would say solitary nodule of thyroid.
Yeah. Yes, sir. If it's like smooth surface and well-defined margins, clinically solitary nodule of the thyroid.
Okay, solitary nodule of thyroid. How will you proceed?
Sir,
In this patient, how will you proceed?
Sir, if it's a solitary, first I would like to get T3 thyroid.
Before you go
profiling
to, can you define a solitary nodule thyroid?
it's a single nodule of thyroid, sir, with well-defined margins and yes, sir, it's a single nodule. I don't know the exact.
Anatomically,
Yes.
anatomically, and by imaging, discrete swelling in the otherwise impalpable or insignificant thyroid.
Yes.
The rest of the thyroid is not palpable or insignificant on imaging, both imaging as well as on clinical examination.
Yes, sir.
So what would be a dominant nodule of a multinodular goiter?
Dominant nodule will be the largest nodule, sir, with solid component.
No solid component.
It'll be the largest. It'll be the
growth.
largest. Yes, sir.
Differential growth.
Yes, sir. Preferential growth.
Compared to the other nodules.
Yes, sir.
Okay, let's say this is solitary. And how will you?
Sir, I would first like to get thyroid profiling done, T3, T4, TSH, following which.
Normal. Next.
Yes, sir. Following which I would want to put the tablet on thyroxine, sir, because the levothyroxine, because the patient is from an endemic place. And
No. See, look. T3,
Wait,
T4,
listen
TSH
to
are
Dr.
normal.
Okay.
Huh.
Got it, sir.
How do you proceed?
Since there are compressive symptoms, I would like to do a total thyroidectomy for this patient.
Oh, no more
surgery.
investigations? No more investigations?
So okay. So
Straight away, tomorrow you will post the case?
No, sir. We're gonna do a video laryngoscopy for this patient.
Before that.
Shreyas,
Ultrasound to
don't
be done.
Confused.
Ultrasound to be done.
Yes. Ultrasound to be done.
Ultrasound shows a solid nodule confined to the right lobe. Left lobe is normal. Assume it and proceed.
Then we do an FNAC, sir.
Okay.
Very good.
Yes, sir. Then we, according to the Bethesda grading, we take a.
Hold on, Shreyas.
Yes, sir.
Suppose the ultrasound comes as TIRADS 4.
Yes, sir.
What is TIRAD 4?
So TIRADS 4 is if it's greater than 1.5 centimeters, we have to do an FNAC, sir.
Explain what is the meaning of TIRADS 4.
So TIRADS 4 is so TIRADS basically we take 5 components into.
Just come to the point. 4 is what? What is in your mind is 4?
Sir, a score between.
What is the final interpretation of TIRADS 4? Final interpretation.
It could be malignant, sir.
No, it is. That TIRADS 4 is malignant. Very high chances
It is
of
malignant. Highly suspicious of malignancy. TIRADS 4.
Yes, yes, sir.
Okay.
So high
FNAC
nodule with less than 2 signs of malignancy on ultrasound. Suggestive,
Yes.
less than 2. Okay. 2 or
Okay.
less than 2.
Okay.
So what features tell you it is malignant on ultrasound? Features suggestive malignancy in ultrasound.
Sir, if there is solid component, if there is tall wider cells, if it's echoic, if there is microscopic calcifications, and with extrathyroidal extension also, we can see it's these are the malignant features, sir.
Sometimes non-palpable lymph nodes can also
On
be picked up.
ultrasound.
Isn't it? Sometimes non-palpable
Yes,
lymph
sir.
nodes
Non-palpable
can
lymph
also be picked up on
Yes, sir.
ultrasound.
Yes, yes, sir.
Yeah.
Yes, yes.
So taller than wider, hypoechoic,
Yes, sir.
vascular, peripheral and central increased vascularity, irregular margin, microcalcification,
Yes, sir.
and presence of lymph nodes, plus or minus.
Yes, sir. Yes, sir.
Okay, shall we proceed, sir?
Yeah.
FNAC reported as follicular neoplasm. How will you proceed?
So,
Which Bethesda will it come under?
Follicular neoplasm,
in
FNAC.
Hemi 2, we can try a molecular and completely evaluate the thing and confirm the diagnosis and do either.
No. Follicular neoplasm is the report from the cytopathologist.
Okay, sir. Got it. So we can then surgically we can plan for either a hemithyroidectomy or a total thyroidectomy, sir.
No. Or this or that. Which one?
So
and how will you decide? How will you decide? Or what criteria you decide? Hemithyroidectomy or total thyroidectomy?
Sir,
are there any
I would
criteria?
Go for,
It is the FNAC, they have just mentioned follicular neoplasm, isn't it?
Yes, sir.
Do you want to know, is it adenoma or carcinoma?
Sir, in follicular, we won't know whether it's adenoma or carcinoma or FNAC because they won't show basement membrane involvement, sir. So we'll do a total thyroidectomy, which is better, and we can follow up the patient.
Why directly total? What is the minimum amount of surgery we can do?
We can just do hemithyroidectomy, sir.
Let me
what
give
are those
you
criteria? Patient is only 33-year-old. Isn't it? Patient is 33-year-old.
Patient
what are the
is young.
criteria?
Yes, sir.
Patient is female patient, young patient, and it is what is the size? What is the size you said? Size of the nodule?
5 into 4 centimeters.
5 into 4. So, are there any criteria depending upon the sex of the patient, age of the patient, size of the patient?
Yes, sir. So if it's greater than 4 centimeters, the prognosis is not good.
Yeah.
Then males have a worse prognosis compared to females, sir.
Age?
Age greater than less than 40 is good prognosis. Aims and ages.
Okay. So if you apply those criteria, what is the best option in this patient?
Sir, her age is less than 40. Her size is greater than 4 centimeters. There is no metastasis and
sex.
Sex is females, so it'll be good prognosis.
Okay. So what is the best option? Follicular neoplasm.
Best option. Hemithyroidectomy would be good for this patient, sir.
Just hemithyroidectomy, or you would like to do something intraoperatively?
Sir, and central lymph node dissection.
Dissection?
No. Can pathologist help you intraoperatively?
The frozen section we can send.
Can
Frozen
pathology
section must be. It must be done.
Yes, sir. Yes, sir.
Frozen section
we
comes
can-
as follicular adenoma. What do you want to do?
Yes.
Hemithyroidectomy done. Frozen section report is follicular adenoma. What do you want to do?
That's also, we don't have to do anything else since it's an adenoma, sir.
Frozen section comes as follicular carcinoma. What do you want to do?
So that time we want to do complete thyroidectomy, sir.
No, the other lobe is normal. Why do you want to remove the other lobe? Other lobe is perfectly normal.
So because so they could be
There is no lesion at all in the other lobe.
Okay, sir.
So why do you want to? What is the reason?
So the reason is that if there, in case later on, if there's any chance of developing a follicular carcinoma in the other lobe,
No. Follicular carcinoma is not multifocal.
Okay, sir.
Papillary carcinoma is multifocal.
Yes, sir.
Follicular carcinoma is not multifocal. That is not the reason for removing the other lobe. What is the reason for removing the other lobe? It must be removed, but what is the reason?
So because
post-operatively, would you like to plan something, treatment?
Radioactive
radioiodine scan.
Yes.
The radioiodine scan I want to plan. So everything will get concentrated in the thyroid if we give this thing.
If
so
you
it's
don't remove the other lobe.
Yes, sir. Yes, sir.
If you don't remove that lobe, everything gets concentrated there. It doesn't show metastasis.
Yes, sir.
So that is the reason you have to remove the other lobe also.
Yes, yes, sir.
Okay. Total thyroidectomy done in this patient. Let's assume total thyroidectomy done.
Yes,
is ready for discharge. What is your advice to the patient?
So one question before we go to surgery, whether it is hemi or total. He was talking about molecular biology, a molecular assessment. What are you talking about, Shreyas?
Sir, I am trying to confirm the diagnosis, sir, using for example, there are molecular testing such as thyroid sequence or Afirma gene sequencing, which will help us to know the exact pathology of the swelling what is present, and we can understand the prognosis. Yes, the probability of malignancy. Yes, sir. It'll help us confirm it.
Can you mention a few of those things?
So like Afirma
mutations.
So mutations, for example, papillary carcinoma, there'll be BRAF mutation, BRAF 600V mutation, and red PTC mutation, and follicular carcinoma will have RAS mutations, NRAS, KRAS, and anaplastic carcinoma will have P53.
In cases where they are not able to make a pathological diagnosis by FNAC, these would help in helping you to differentiate an adenoma from a carcinoma.
Yes.
Before you subject the patient for hemithyroidectomy.
Yes, sir.
And looking at the good features, people would also argue that hemithyroidectomy could be good enough.
Yes, sir.
Unless it is an invasive variety of follicular carcinoma. Minimally invasive variety or a follicular adenoma, you can still, with an age of 33 years and only size being the criteria, bad criteria, you can still do a hemithyroidectomy, provided it is minimally invasive.
Okay, sir.
What post-operative complication you expect, Dr. Shreyas?
Sir, since so post-operative complications in this patient specifically, sir. So they could be since like there is compression of the trachea and there's dysphagia and dyspnea and all, they could be recurrent laryngeal nerve injury during dissection, sir.
Superior laryngeal nerve. Superior laryngeal nerve also is in danger, or no?
Superior laryngeal nerve will also be in danger, sir. But yes,
external branch. External branch
of superior laryngeal nerve. Yes, sir. Yes, sir.
Parathyroid is in danger.
So parathyroid, since
yes,
it is in danger, sir. Yes, it'll be difficult to dissect. Yes.
Okay.
How does superior laryngeal nerve injury manifest, Dr. Shreyas?
Sir, yes, sir.
How does superior laryngeal nerve injury manifest? or
So,
external branch of
superior laryngeal nerve basically supplies the cricothyroid muscle, which is the tensor of the vocal cord. So the pitch, basically for singers and all, it's really important. The pitch will be lost.
Very good. Anything else
Yes.
in the postoperative period?
And the
If you
sensation
do
will
indirect laryngoscopy,
yes, sir.
if you do an indirect laryngoscopy, what would you see?
Yes, sir. So it will be in paramedial intermediate position, sir.
No.
Tensor of the vocal cord. So what happens?
Yes, sir.
That
so
if the
since
tensor is paralyzed,
so it'll be abducted, no, sir.
it sags down.
Okay, sir.
Sagging.
Okay, sir.
Which muscle
Patient
does
will
it
also have
supply?
problem.
External laryngeal?
Cricothyroid muscle. Cricothyroid muscles.
Yeah.
What are the anomalies of the external laryngeal nerve in relationship to the superior thyroid artery? What relationship does it have to the superior thyroid artery?
Sir, it goes very close to the superior thyroid artery, sir. And so we have to be careful.
I mean, is there any classification, varieties of its relationship to superior thyroid?
So that I don't know, sir.
Type 1, type 2, 2A and B. Type 1 is more than a centimeter above the superior margin of the upper pole of thyroid, where it can cross the superior thyroid and go to the cricothyroid muscle. Type 2A, less than a centimeter from the superior pole. And type 2B, it goes across the superior pole. So that is the reason that your ligature should be as close to the superior pole as possible.
Close as possible. Yes.
We will have two more questions, one from Srivastsa and one from Kotennavar, because we have crossed the time limit. It is 10:10 now. One question from Srivastsa and one question from Kotennavar, please.
Dr. Shreyas, what is the early postoperative complication? Name any early postoperative complication.
They could be hemorrhage. They could be difficulty in breathing, sir. Because the
hemorrhage is the
patient
most
could have
common, isn't it?
yes, hemorrhage
What
is
do
the
you mean
most
by
common,
reactionary hemorrhage? What do you mean by reactionary hemorrhage?
So reactionary hemorrhage will occur approximately like around 8 to 12 hours after surgery. There'll be when we place the drain, there'll be excess like blood coming out of the drain, and the patient will have difficulty in breathing. So we have to release the sutures and go explore and
what are the causes of reactionary hemorrhage? What are the causes of reactionary hemorrhage?
Ligature or so slippage of ligature, or if there is hypertension, which could make the ligature slip.
Very good, very good.
What is Behr's triangle?
Which sutures will you release? There are layers of sutures. No? Which
the strap muscles we have to release, sir, to
the collis fascia and the strap muscles. Okay.
Yes. Yeah.
What is Behr's triangle? Behr's triangle.
So Behr's triangle is used to identify the recurrent laryngeal nerve. It is it composes of external carotid artery, inferior thyroid artery, and the recurrent laryngeal nerve.
External carotid artery. External carotid artery goes
common
carotid artery, inferior thyroid artery, and it yes, a common inferior thyroid artery and recurrent laryngeal nerve, which is close to the tracheoesophageal groove, is the other part of the yes.
Medially trachea, laterally common carotid artery, superiorly inferior thyroid artery. In this triangle runs the
inferior thyroid
recurrent laryngeal nerve.
Recurrent
what is
laryngeal
the tubercle of Zucker and its importance? Zucker
tubercle of tubercle of Zucker thyroid gland, sir.
No.
Which could be
it is present in nearly 60% of thyroids, and it gives you an indicator of vicinity of that portion of thyroid to the recurrent laryngeal nerve. It indicates that the recurrent laryngeal nerve is close by. It's a developmental enlargement like a nodule on the posterolateral aspect of the thyroid lobe.
Yes, sir.
So these two are indicators. One is the Behest triangle. The other is if you have a Zucker candle, which is there in 60 to 65% of thyroids.
Yes.
Sir,
Okay, shall we
questions
have some assessment, sir? Assessment?
Yes, I think you should give the assessment because he has been my student in the past.
Yeah, he has done well, I think.
That's a fair
He-
presentation, sir.
No,
Good presentation.
one thing which I appreciated is that when he did not know answer, he said, "I don't know." That is the best answer from a candidate who doesn't know the answer. And instead of beating around the bush and trying to bluff and trying to, that
Escape
is the
out,
best.
come out.
If you don't know, please say, "I don't know," because none of us know answers to all the questions,
Yeah.
including examiners. None of us know answers to all the questions.
Exactly.
That is one thing which I appreciated in him. Otherwise, he has done well. And what's your opinion, Dr. Sreevathsa?
Yeah, he has been my student, so I cannot give my opinion as far as the presentation
you
is
should
concerned.
you should be unbiased in judging. Unbiased.
Yeah, I would say the presentation has to be a little better.
Yeah.
He can make the presentation perfect in the future, so it doesn't miss those points that we mentioned on inspection palpation.
Okay.
And if he is going to the third year, the final year, I'm sure he would become better with the knowledge of anatomy and the management of thyroid malignancy. But
thank you, Dr. Kotennavar. Any
I
comments from
agree with you,
Thank you,
sir.
sir.
I agree
Thank
with you. It was a best presentation. Only thing you should little bit read about the basic things, sir, like anatomy, physiology, what is the rationale behind getting the investigations,
Yes.
and the principles of treatment.
Yes.
Long way to go.
Yeah.
Well done, Dr. Shreyas.
Thank you, sir.
Thyroid
Thanks
is
for
a
Definitely
very common case kept in the examination.
Yes,
And
thyroid is best.
a very common case and a very good case to discuss also.
Yes.
And mistakes, blunders are not tolerated because this is a very common case for general surgery examination, MS examination.
Yes.
Mistakes are not tolerated.
True.
So you should be very thorough.
Yes.
Dr. Shenoy, your comments, please.
Nothing, sir, that both postgraduates, you have done well, number one. Very fact that you have volunteered to present itself, it an indication that your eagerness to learn. Okay.
It needs
That's
guts
why
also.
I appreciate both of you because you know the knowledge, you know the resources, you know the material, plenty available in online, various forms. But remember, these are the examiners who ask you questions. And always when you present, this is for both candidates, don't present like a judge. You say that thyroid gland moves with the deglutition. You don't have to do the interpretation telling that it is deep to the deep fascia or pretracheal fascia. That's where you are caught.
Yes.
Yes or no? So
Yes,
it's for leave it to the examiners, no? What
Yes.
does it tell you? Actually, what you told was right. It nothing wrong in that. Because it is not about, it's only this is the place where inspection also, because it is deep to pretracheal fascia. That's why it moves with the deglutition. So what I'm trying to tell is you have to reason it out. Don't come to judgment. Judgment is examiners will ask you questions. Anyway, both candidates, both are very interesting cases, sir. Both are, and of course, lot many things for postgraduates to know about first part obstruction. That's for the first case, Dr. Shivmani's case. First part obstruction, second part obstruction, third part obstruction, fourth part, all that will be asked. Because examiners know, probably you may know the diagnosis. So we would like to take you to different aspects about that. Overall studying. Okay, well done, both postgraduates. All the best to you people. Thank you, sir.
Thank
and
you.
also examiners and Dr. Godhi, sir, from my personal behalf. Thank you very much.
Sir. Thank you very much, sir, for the opportunity.
Dr. Naaz, you can unmute yourself. Naaz?
Yes, sir. Good evening, sir.
Can you unmute?
Yes, sir, yes, sir.
Second
Yes,
lady chairman of KSCASI.
Thank you, sir.
Yeah.
Excellent presentation by both the presenters, and I had a lot to learn from both of them, and the excellent discussion from all the teachers. Thank you so much, sir.
Thank you. Sarvesha, Raje?
Thank you.
Sir, your
Sir.
final comments?
Sir, before me, I request Dr. G. Siddesh, past president, to pass on the comments with your permission.
I'm not able to see him.
No, I'm here, sir. Probably you're not recognizing me. Thank you. Anyway,
No,
thank you, Srinivas.
you put on your camera.
Yeah, it's on, sir.
Yes, sir, I am there on.
Okay.
I wanted to speak. Thank you. I just wanted to one comment. After such a long gap, I'm seeing senior most examiners again on the live. Dr. Godhi sir, Dr. Srivatsa, my dear friend. I'm
Thank
seeing
you.
you for after a long gap.
Yeah.
And your favorite topic of thyroid, I'm really happy. It's a revisit of your. We used to enjoy your examinership and as a colleague examiner in Anmaya and as well as in Ramaya whenever you used to come. Very nice. And Kotennavar, thank you. I think you all contributed. My only observation of today is students have done okay. It's not that they have been extraordinarily good, but it is a learning process. They always have scope for learning. But unfortunately, the numbers speak. Though the numbers is moderate around 45, 50, I think at the peak. But majority of us are as teachers only are there. And I are rather surgeons. We are willing to learn still when the opportunity is there. But postgraduates, I don't know, they may see these things later on. I don't know. Is it available on the live? I mean,
Yes.
recorded version is available. I hope they visit and then take benefit of this. It was such a valuable contribution by senior doctors. So, and our chairman is also a very good academician. So,
One more
anyway, it's
thing.
a good team putting up good show. Sarvesh, thank you. You are doing a good job. And Madam Naaz, congratulations again.
Yes, thank you.
Keep doing. Right. All the best.
Yes,
Dr.
thank
Preethi, can you unmute? Can you unmute, Preethi? Dr.
So
Preethi?
one more thing. Godhi sir, one more thing. We
Yeah.
should be able to answer some of the questions asked in the chat box.
What are the questions? I'm not getting the chat box.
Yeah, already I think it is time is over. But next time onwards,
I-
sir, we should be able to answer the questions asked in the chat box by the viewers.
I think it is too late now. It's
Yes,
now
sir.
10.
Next time. Yes, sir. Please, sir. Next time onwards. Okay.
Thank you.
Thank
Thank
you,
the
sir.
organizer.
Dr. Preethi, just she's just
Good evening, everyone. So, Siddhartha was just saying whether about the students not participating. In fact, we have done a WhatsApp group of all the PGs, and I directly communicate whatever programs we are doing from KSCASI. I see to it that it is communicated to all the postgraduate students of all the 3 years. But still, unfortunately, very few participate in it. But however, it is available on YouTube, so probably they'll come back and watch it. Anyway, congratulations to both the presenters. They did a wonderful job. And I hope whoever watched it, the students will get to learn a lot from this.
What was the maximum number of participants, Dr. Sarvesha Raje?
36, sorry, at present I'm seeing 31.
It had crossed around 70, sir.
70, it is. In
Yes,
between, they used to come in and go out, move out actually.
Oh, okay.
And the live streaming is there in YouTube also, other than the recording.
Mm-hmm. That number we can't know that number, YouTube.
Martin?
YouTube, currently we had 35 viewers, sir.
Uh-huh. Okay.
So by tomorrow it might reach around 200, sir.
Okay.
Good.
Thank you.
That's
Thanks,
good.
everybody.
Thank
you very much.
Sir. Thank you, Dr.
Bye.
Sarvesh.
Good night.
Very nice.
Dr.
I
Godhi,
feel both the PGs
Siddesh.
were blessed to have the presentation here in front of the stalwarts. And I request Dr. Gurubasavana Gouda sir to present the vote of thanks. Are you there, sir?
Yes, sir. Thank you very much
I
for
saw
giving
him.
me
Yes.
this final opportunity at this great PG clinic class. Thank you, sir. Thank you. Wonderful, the postgraduate students you presented very well. What I am seeing now, just a small comment, sir. In the last few months, there is a gradual improvement in the postgraduate presentation, sir. Saying that, I thank moderator, Dr. Godhi, sir. I thank examiners, Dr. M.R.Sreevathsa, sir, Thank you very much. I have seen you after a long time. Thank you very much, sir. I also thank sir with the brain behind this PG clinics, our favorite chairperson here, Dr. Rajgopal Shenoy, sir, and my secretary, Dr. Sarvesha, others. And I thank my past chairman, Shivmani madam here, Lakshman sir, and others, Siddesh sir, national president, past national president, and of course chairman-elect Dr. Naaz madam, other postgraduate students, other faculty who could able to make this PG clinics and contribute much of things for this PG clinics. Thank you one and all for being part of this program. Thank you very much. Say good night.
Good night.
Thank you, sir.
Good night.
Night, everyone.
Night, everybody.
Thank you.